So once again, I just want to thank God for the privilege I have to share a part of my life story. Some of you may be familiar with parts of my life story, and I hope that some strands in the story will resonate with your own personal life journey. And all of us, God has given us unique life paths, right? But there are so many principles probably we can learn and share with each other. And what I hope to do in the next for 35 minutes is what Tony has given me. I want to try and see if I can finish it in 35 to 40 minutes and leave some time for Q&A. So and what I've called this presentation, and I'm going to share my screen, is I'm just coming to the slides. So are you able to see my screen?
Yeah,
Yeah.
we can see it.
Yes. Yeah. And so I'm going to share this thing. So now it's on full screen, right? I hope that's clear.
Yes.
Yes, Tony, just give me a head, thumbs up. Yeah, that's fine.
Here. Yep.
Right. Okay. So I've titled this presentation as Sowing Seeds for Transformation in North India. And it's a joint effort which my wife, Ligia, and myself have been involved in over the last 20 years. And we thank God that He has given us the privilege to be ambassadors for Him in this part of India. Right now, we are in Kerala, but we spent, as Tony mentioned, a good part of our lives in the northern parts of our country. This picture is of the Believers Church Medical College hospital, and some of you who do come to Tiruvalla in central Kerala can visit us. It's a beautiful place in the middle of nice fields, and it's a treat to come over here. And this is where we are currently located, but we are still quite connected with the ministry in North India, and that's what I want to share with you. My presentation today will be a bit unconventional. It's not going to be so much scripture based, but I'm going to weave in scripture along with some life experiences in the hope that God will speak to your hearts as we share the experiences. My personal story is that I was fortunate to be born in a Christian family which had a deep passion for the things of God. My grandpa, Pastor P.M. Philip, whom some of you may know, was already an evangelist, a preacher, and he had inspired my life. At the age of 13 years, in a meeting which he was preaching in Chennai, where I grew up in Chennai all my life, and I gave my life to Christ when there was an altar call. I had the privilege to get admission at the Christian Medical College in Vellore for my undergraduate training. And while I was in Vellore, we were privileged to have many missionaries from North India come during our CMDA or ICMDA like meetings, the EU meetings, we used to call it, the Evangelical Union. And we used to listen to the stories of many missionaries who worked in various parts of India. And that really moved me to tears many a time. But often I felt in my heart, maybe I didn't have the ability to perhaps one day be able to go and serve in places of need. When I was a young boy in my third standard, I did read a small chapter in my English textbook about this lady called Dr. Mary Verghese. She was a medical intern at the Christian Medical College in Vellore, and during her internship, she had an unfortunate accident and she became a paraplegic. And she lost her power of the lower limbs and she was confined to a wheelchair. She thought life had finished. But there was a gentleman from the United States, Dr. Paul Brand, who was a missionary doctor in CMC Vellore. He inspired her and said, Lord, so what if your legs are gone? You can use your hands. And she prayed a prayer, Lord, take my hands and make me useful for kingdom purposes. And she became a big inspiration to many generations of doctors and students. And as a young boy, I'd read about this lady. But I never thought I would get to meet her in person in the late 80s when my dad used to work for World Vision International and for World Vision India. And the founder of World Vision is an American called Dr. Bob Pierce. And he had this famous prayer which he prayed when he was looking after Korean War refugees in 62. He said, he prayed, Lord, let my heart be broken with the things that break God's heart. And this is what birthed World Vision as an organization. And he started off with $10, which he set apart from his savings. And then many people joined in. And today, World Vision is a huge humanitarian organization globally. And my dad worked there for 27 years as one of their senior leaders. And in 1988, the Bob Pierce Award was awarded to Dr. Mary Verghese, this doctor from Vellore, who was on a bed in CMC hospital. And my dad was requested to go and hand over the medal and 10,000 US dollars as a award to her from the World Vision US. And my dad, when he went, he took me along as a little boy. I was just 15 years old. I had an opportunity to visit her on her bedside, and I met her, I got to interact with her, and her conversation struck a deep chord in my life. How even if God takes away something from your life, you still have something you can give. And she said, "Take my hands." And this is the book which I read in at that time. And this is a very, very touching book. And along with Dr. Paul Brand, who inspired her, his book as well touched me. And so when I joined medical school in 1990, by the time she had passed away, but this memory remained in my heart. This is the Christian Medical College at Velo. I'm sure some of you may have visited or seen this place. And this is the institution which has shaped my medical career in many ways and continues to be a great inspiration for me as an alma mater. This is my foster parent in Velo. We had foster parents who adopted the medical students when they joined medical school. Dr. George Shandy, who's currently the director here at Believers, was my foster parent. They provided me a home away from home at Velo. The gentleman on the top with the suit is Dr. Lionel, who was the mentor for the Christian Medical Fellowship at the CMC Vellore. He was a urologist who committed his life to student ministry on the Vellore campus. And they were faithfully opened their homes for us students to come to their home whenever we had difficulties and challenges. And the gentleman below is Sunny Philip, a gentleman from Australia he's an Indian Malayali who married an Australian person. They came and volunteered in Vellore, and they also provided me home away from home. And these are three families who opened their homes to me as a student for fellowship, encouragement, and times when I'm down. And they helped me in my Christian journey. And all three of them are still very connected to me after 35 years of me joining as a medical student. And I must say, these lifelong relationships have shaped and mentored my life. But as a young medical student, I got a chance to visit North India. And if you see this British gentleman on the left, he's a surgeon who trained in Gloucestershire in the UK. His name is Colin Binks, and his wife, the Wendy Binks, is at the background. You may just about see her picture. Is this slide visible, Tony? Yes? Yeah. So this is their home in Jharkhand in a place called Navjeevan Hospital. Dr. Binks was a very good trained surgeon, and he came and served for 30 years in Jharkhand, that was erstwhile Bihar. As a surgeon, he did obstetrics and gynecology, general surgery, urology, plastic surgery, you name it. And as a young medical student, I visited him at his invitation, and that visit really made a huge impact in my life. And can you believe it, till today, every Christmas, he sends me a Christmas card with a handwritten letter to encourage me, even now. And even 2 weeks ago, I did a Zoom call with him. That is consistency and walking with you through life's journey. And he used to tell me, Philip, I think you're gifted as a physician. He trained me up in surgery when I was a young junior doctor. I used to do cesareans, hysterectomies, hernia surgeries, all trained by Dr. Binks. And currently he's retired. He's back in the UK. He's not keeping very well, but he makes it a point once in a month or two to call me and just inquire how I'm doing. And I must say, this person is one of my mentors. We have two young people here, Dr. Vijayanand and Ann, who are a pediatric surgeon and an anesthesia couple who started the work in Assam, in Mukunda Hospital, Leprosy Hospital, who also, along life's journey, have inspired me a great deal by their sacrificial service. And right at the bottom is Dr. Vinod Shah, a gentleman from a Jain family background who accepted Christ at CMC Vellore, became a pediatric surgeon, and was the CEO for EHA, the Emmanuel Hospital Association, which is the organization which is the largest indigenous medical mission organization in India, under which all these hospitals where I work come. So as Tony mentioned before, I've had the opportunity to be there in EHA for about 10 to 12 years. My wife also had a very parallel experience. She was inspired by a sister and brother-in-law, Dr. Manoj Jacob and Manju, who started a mission hospital in Orissa in the tribal parts called Asha Kiran Hospital. They, along with two other couples, wanted to spend their life in something which is different from the usual path. And my wife, as a young doctor, happened to visit them much before our marriage. And she had already committed her life to serve in missions. And I think when you pray for your families, we don't know how God works, but God brought our families together, and the proposal came, and then we had a chance to live after that together, and we got a chance to visit these hospitals together. And Lygia has been a great support to me, and I must say, without her support, I don't think I could have been able to do even half of what I talked about. So I'm going to share a little bit of my life experience in the North Indian mission field. And this is just a brief sketch after my training. I worked for 2 years in Jharkhand and Assam in these two hospitals. And After I finished my MD, that's internal medicine residency, I didn't have any obligation, but God led me to go along with my wife, and our first son was born in this hospital called Christian Fellowship Hospital in Tamil Nadu, a place called Odinchadram. And thereafter, we felt God was clearly calling us to work in North India. And Legia did her anesthesia residency in CMC Vellore, and I did my endocrine training while we were there. And thereafter, we worked for 8 years in Bihar and 2 years in Assam. And in between that, when it was about 8 years, we were also feeling the need to upgrade our knowledge. And Legia did her palliative care training at Cardiff in Wales, and I worked as an associate specialist in Basildon University Hospital, about 40 miles from London. And the last 9 years, God led us to come back to Believers Hospital. And that story is another story which I will tell at the end of it. Why did we come back to Kerala? Actually, we were not planning to do that, but God had his plans, which are very different from ours. If you have heard about Roxol, as Tony mentioned, it's a border town of India and Nepal in Bihar. And this is where we spent 8 years of our life from 2007 to 2017, with the gap of 2 years when we went to England. It's a predominantly agricultural economy based place. 92% of the people work in farms and they're agricultural laborers. This is a very busy road on Vauxhall in those days. You would see pony carts, cycle rickshaws. This is not uncommon at all. And people, even people pulling these carts and going along. And this being a very dusty, dirty town. But many years ago in 1930, some Scottish missionaries with a heart to reach Nepal for Christ reached this place because they were not allowed to enter Nepal. They came and set up a mission hospital, which has been an inspiration to lead many, many people from across the border to come here, get medical services, and also come to know Jesus Christ in their life. This is the entrance of the Duncan Hospital. If some of you want to come, this is what will welcome you. This is established by Scottish missionary doctors way back in 30s. And in 1970s, the Emmanuel Hospital Association, which is an indigenous fellowship of Christian doctors, took over this hospital from as the expats were being asked to leave the country. And this has been the largest hospital of our network of mission hospitals in EHA. Bihar has been previously known as the graveyard for the missionaries because somehow many, many hours and days and years of missionary lives have been poured out into the state. But the results were not very forthcoming, it appeared. Until the last 10 to 20 years, we have suddenly seen a windfall. Now, Dr. A.B. Matthew, a gentleman who works with India Mission, recently wrote a book called No Longer the Graveyard. And that just shows how there's been a market shift. But many people have sown in tears in this particular place, given up their whole lives without seeing a single fruit. But it's only in the last 10 years we have suddenly started seeing many, many house churches and people coming to Christ. And EHA is fortunate that we have two of our hospitals in two areas, one in Roxol and one in Madhipura, in two parts of Bihar, where God's name is being glorified and we're able to reach out to the communities there. And this hospital is located in North Bihar, Duncan Hospital. This is a picture of the new block of the Duncan Hospital, which was inaugurated 10 years ago. And I will tell you a little bit of the story of it later. But it's the only hospital in the Christian hospital in that whole region for 10 million people on either side of the border. There is a medical college on the other side of the border, but has only very basic care. There is no good secondary or tertiary care set up for kilometers up to a 6 hours journey on both sides of the border. This is a very busy 200-bed hospital, secondary come tertiary level care, which we offer here. That is a picture of the ICU, where we have about 10 beds, with many of them who need ventilation are brought here to the ICU. We were a small team about 8 years ago when we were there, 8 consultants and 19 junior doctors working flat out day and night. I used to be on call alternate day for many years. And it was not very easy because one day you get a sleep, my colleague will be there. When he takes leave, you're on call every day. So as not as a first on call necessarily, it's only the first year we were there. We didn't have enough junior doctors. We had to take first on call. So that is, but then later on became second on call, but with very raw hands. Sometimes it is almost like being first or second on call all the time. But God gave grace. As the burdens go greater, we read, no? God's grace grows even more greater. And I must say, it's purely the grace of God we were able to survive there at that time. But there was a joy of serving people who would never be able to pay you back. And it is a joy to also be able to freely share the gospel with them, with every patient who came to this hospital. And that was a big strengthening experience. That's a close-up view of the hospital. We have an ABG machine as a point of care testing right in the hospital. Most of our patients admitted here had either infectious disease, tetanus, and as well as organophosphorus poisonings. And I'll talk about it. And this presentation is going to be a bit different. I'm going to talk about some medical conditions which we treated and how those experiences were channeled for kingdom purposes in the days to come. We had a large number of deliveries because 80% of women in that region deliver at home. Only 10% go to any health facility. Maybe we used to see 2 to 3% of the deliveries in that region in our hospital. And we had about 6,500 deliveries a year in our hospital. That's about close to 300 to 400 deliveries a month, no, at least. And this is a warmer which was there, which had three babies because we didn't have enough warmers for the babies who were born. So sometimes you can see how resources are very scant, but God was very gracious. Now the hospital continues to grow, and I'll tell you the amazing way God has blessed the work there. It is not just a hospital. We used to say we are part of a family. We are all part. It's ultimately the Lord's work. God brings in different people with different skill sets. There was a school of nursing started about 50 years ago, which had 100 nursing students. There was a school of lab technology. The academy was where my children studied up to grade 6. And we also had a vibrant community outreach program in the villages around our hospital where we could reach out to the people right at the grassroots through our team of people who went out almost every day in various spheres of community outreach work, like community-based rehab and other work. So I worked 8 years at the Duncan Hospital, both as a physician and an endocrinologist. Even though I had trained in endocrinology, I would say 70 to 80% of my work was as a general internist. I had a fairly busy OPD, but it's not me alone. Many of my colleagues used to chip in and help us in the OPD. We used to see about 100 to 150 patients a day, but we had about 40 inpatients. But we used to be able to care for them to the best of our ability with the available resources. And I never thought of doing any research, honestly, when I went to Roxol in 2008. But what I'm going to share with you is that how you can do research even in small places, meaningful research which will impact and change communities and let your kingdom come even in those places. No, we can see that prayer being answered. But various situations came into our life. You can see the pictures of these homes where most of my patients used to come from. Small thatched huts in which about 8 to 10 people would live. And sometimes in the night, the cattle will also be taken in because they are afraid somebody will steal them out. They leave them out. So you can see it's quite a bit of poverty in that region. But there were a lot of people in the middle class and affluent group as well. But about 70% of my patients used to come from homes like this. So they are not very well to do. So, as I mentioned, I'm going to share with you how most of you I know are physicians or medical professionals, and you may be able to understand some of these things. And I'm just sharing this to inspire you, perhaps to consider also doing something similar in your own context, what may be appropriate. I was shocked and pleasantly surprised to see this publication in the Lancet, which is a very famous journal like the New England Journal of Medicine, in way back in 1977, about how there was a study on 322 patients who came with generalized tetanus in the 70s. And Dr. Sanders, who's the first author on this paper, along with Dr. Peacock, who's a senior author, published this paper on how they gave intrathecal anti-tetanus serum to better manage tetanus. And this is one of the largest studies where they observed people consecutive patients. One group they only gave intramuscular anti-tetanus serum. One group they gave intramuscular plus 200 units of ATS. Those days we didn't have immunoglobulin, right? And their results show that if you give intrathecal, it gave better results than just giving intrathecal by intramuscular route. And they were able to show through good nursing care, many of these patients with tetanus would survive. Otherwise, it is a bad disease. And they managed to publish it with the help of one of Dr. Sanders' wife, meticulously documented all this, and they got a high value publication. And this led the world to notice that you can do high quality work even in resource limited settings. The key, as somebody says, is the teamwork, which is the key to success in research. And you all know it. I'm sure you're doing it all the time. When I went there first, we noticed that I was treating a lot of my time was spent in caring for women and young people who had consumed organophosphorus poisoning as well as aluminum phosphide, which was quite lethal, and mixed pesticides because agricultural communities, people having a difficult time, these pesticides at home, you can just dunk half a bottle of it and you can develop all the cholinergic crisis symptoms. So I was very happy that we used to have young lady. This lady had taken organophosphorus poisoning. We had ventilated her for 4 to 5 days. She recovered. and with atropine and pralidoxime, and she did very well. We were happy to let her go, but we realized that is not going to solve the problem. She could come back again because we have not looked deeper into the issues, why she's doing this. And our statistics from 2007 showed we had about 80 admissions due to organophosphorus and other poisons. And the years we were there, we saw steadily it was rising. If you notice that 2010, there's no number. It's not that nobody came. Our statistics was not correct. And we thought we would rather not have that statistic than to present something, no, which is not correct. So I told our junior doctor we won't present because we don't have the correct value. But the rest are all, can you see a steep rise in admissions and poisonings in our hospital? And then we realized we became famous as the poison care hospital of that region because patients used to get better, word of mouth. People knew that if you come here, your life will be saved. But we were not happy with that. Just saving them at the crisis is good, but even better would be to probe deeper. And as we were praying, Lord, what can we do to probe this better with the heart? What we realized is we suddenly had a young lady called Sangeeta Nair from Gujarat who approached us saying she's a psychologist. God has given her a calling to come and serve in a mission hospital where we are. Can she be of some use? And lo and behold, the dots were connected, and we found, wow, why don't we use Sangeeta's expertise to explore why are these people attempting suicides? We know those who have attempted will not reach or who died, but the ones who come to the hospital. So she did detailed interviews on close to 200 to 300 patients who attempted suicide and their families. And we found it is not poverty. Most of the time, it was interpersonal conflicts and impulsive attempts, impulsive actions, which led to many of them attempting suicide with pesticides. And this was published in the Christian Journal of Global Health later. And you could later on Google this. This presentation is available for you if you want to use that to look further. And that led us to start a mental health project in the villages, saying it's not enough to just to sort of know about this or treat and get these patients better. We formed a small team of our team who used to go to the villages and identify the high risk people who are likely to commit suicide, especially wives of alcoholic patients and other problems. And the villagers would tell us, oh, that home there's a problem. I don't know. Seems to be always yelling and shouting. And so these team members would go and counsel them, spend time with them, be support to them. And that is what is called the Roshni project, meant light in the midst of darkness, was what we meant by the word Roshni. And our project, our people used to go and attend the village. You can see many of the women working in the fields, they would have teaching sessions right in the paddy field. And one of our doctors, who was a young doctor who later became a psychiatrist, as only psychiatrist in that whole district, was teaching for many of doing health education for many of the people how to handle stress and how to go about stress management in a very meaningful way, weaving in Christian principles as well. And this is the mental health day. We are having skits in the community around about how people attempt suicide. So the word of mouth people spread that if you have a difficulty, there's a person you can go to for help and support. There's nothing called helplines available in that region at that time. I never thought I would ever become a semi expert on snake bite, but the fact is we had to treat close to 500 snake bite admissions every year, especially in the rainy season when the snakes would be flooded out of their burrows in the fields. And we investigated this because it was a problem. And we had one of our family medicine students who was interested in doing a project with us in Roxol. And we discovered two key learnings. Very often, many patients were brought dead to the hospital because they couldn't organize the transport quickly and they would not reach the hospital in time. And there were many barriers to patients reaching the hospital. And most of them who survived, we thought it was because they had some other they didn't develop envenomation, but we often discovered patients were also misidentifying snakes. Cobras and crates were not the ones which were biting. Sometimes it was other snakes. For example, one day we had a patient who brought in a live cobra to us saying this is a snake which bit me in a gunny bag. And then we had a difficulty how to get rid of the snake after we saw and identified it. Of course, the patient survived, but he had a very bad skin reaction and envenomation as well. This is the common crate which bites in the evenings, and this is the common perpetrator of deaths among patients who come with snake bites. And this is the commonly mislabeled snake called the wolf snake, which used to be brought to our hospital. And the patients thought this was a crate because these bite in the evening times and they cannot often identify which snake bit them because they are all in a state of fright and shock. And that led us to publish a work on human snake and environmental factors in human snake conflicts in North Bihar. And this was published collaborating with our friends who had burden for similar issues. And this was a study on 609 patients published in the Christian Journal of Global Health a few years ago. You won't believe it. When we published this work, we didn't realize that the WHO Southeast Asia Snakebite Group would pick up on our findings and publish it in their manual how we can prevent snake bites in many parts of the world. And our research is thankfully now impacting worldwide guidelines in our part of the world on snake bite treatment. And we were invited by the Oxford University as well to do a poster and a presentation while we were in UK. And we also got an opportunity to specifically train our patient relatives how to prevent snake bites. And will you believe it? We also printed a tract. My colleague Lois from Australia, who was working with me, had a chance to write a tract about to share about the one who was lifted up, like the snake Moses lifted in the desert in John 3:14 and 15. And we got to share about Christ as well through this particular encounter we had with families who brought their patients with snake bite. So when you do need-based research, there is a huge impact and transformation. Often I realize in big institutions, sometimes we have pharma companies wanting us to do
പറയടേ പറ
trials
ഹലോ
and other things which are good, but sometimes
എടാ
may
ഞാൻ
not
ഒരു
address the felt need of the particular community.
ഞാനൊരു മീറ്റിംഗിലിരിക്കും അതുകൊണ്ടാണ്.
So endocrinology related research, I thought I'd shelved endocrinology, but God gave opportunities to use our training as well in this area. I remember when I went to Roxol, I found a lot of people coming with acute onset quadriparesis. About 25 patients a year admitted. Many of them were the same patients coming again and again with recurrent admissions. They would be given IV and oral potassium and discharged within 24 hours. But often I realized nobody was delving deeper to see why did they get this problem. And that prompted us to do a thorough investigation into this issue. And my predecessors who had been at Bihar and Roxol had shown and published that often it was hypokalemic periodic paralysis, which was the cause for acute onset quadriparesis in this region. And this is well known, but nobody had delved to know why they were getting hypokalemic paralysis. And when I was in my training at CMC Vellore, we had just published a paper, my colleagues, on the etiological, clinical, and metabolic profile of hypokalemic paralysis, single center experience. And this showed that many of our patients had renal tubular acidosis, some of them had Conn syndrome, and some rarer possibilities. So this had to be done. I realized in my heart, it was almost like God showing me, you must find out why are these people getting recurrent episodes of hypokalemia. Many of them used to be below 1 when they came to us, the potassium. They could have a ventricular arrhythmia and die if you didn't treat the root cause. And so we said we will identify the causes and we developed a simple algorithm for most of the smaller hospitals in North India. We had the largest study in the world, as far as I was aware at that time. We collected prospective data from 84 people over 3 years, from February to Jan 2012, a fairly equal gender distribution. And many of our patients were actually quite young in the mid 30s. And we found that unlike a tertiary care hospital where you have referred patients, here we were seeing patients as a first or second contact. And many of our patients were presenting in the summer months. And the postulate we had was they are probably drink very high sugary drinks to weather the heat. And that can push your glucose up, leading to insulin being produced and pushing the potassium intracellularly, the transcellular shift, leading to patients getting acute quadriparesis in predisposed individuals. 87% of our patients were those who presented in the hot season, which was not a finding in world literature at that time. And 80% had an underlying cause. And majority of them came to us with potassiums of less than 2, which are dangerous. And as I mentioned, the other findings I did mention before. One of the patients we had to cardio work because he came in a ventricular arrhythmia. And this experience of studying these 85 patients prospectively led us to publish in the British Society of Royal Society that most of the causes of hypokalemic periodic paralysis in rural northern India have secondary causes. And it's very important to publish this for people to be aware. Otherwise, in Harrison's textbook of medicine, what is talked about is a bit different. It's about different type of channelopathies which lead to hypokalemic paralysis, but renal tubular acidosis and Conn syndrome coming like this is not so well highlighted. And so we had slightly different data to present and publish. And this is a simple algorithm we developed for people who serve in smaller hospitals where we don't have all laboratory support, to how with the help of an ABG we could categorize the underlying causes and treat them so that they don't keep getting recurrent problems with hypokalemia. Like if you have Conn syndrome, if they cannot afford surgery, putting them on spironolactone will prevent them from again and again tipping over into a periodic paralysis. Thyrotoxic patients can be easily managed with carbimazole or methimazole. And people with renal tubular acidosis, we had put them on long-term treatment with soda bicarbonate as well as with potassium, and many of them who had vitamin D deficiency were given calcitriol. So if you could identify what the root cause, it made a huge difference. And that is what we felt. Why Mission Hospital doctors should do research is a promise. We felt in Proverbs 31, 8 and 9, it says, to speak up for those who cannot speak for themselves, for the rights of all who are destitute, to speak and judge fairly, and to defend the rights of the poor and needy. And yet another last problem I wanted to highlight is we noticed there was a lot of glucocorticoid misuse in the area. In a 6-month study, we found nearly 22 people were seen who came with iatrogenic Cushing syndrome or hypoadrenal crisis, and the majority of them had already developed the problems of long-term steroid use, such as cataracts, diabetes, hypertension, and 12 out of our 22 people had already developed osteoporotic fractures of the spine, compression fractures, which was just on screening we picked them up. And this led us to publish this work in the British Royal Society journal called The Tropical Doctor. Collaborating with my senior colleague in Velo, we published this. And then we said it's not enough to publish hospital data. We must also publish some work in the community. And we went into the community and did a cluster sampling survey where we looked at 240 households in that period of time from April to May 2013. And we found nearly 1/3 of the population was using steroids for one way or the other inappropriately. And that was probably putting a large number of that people at risk of a suppressed hypothalamo-pituitary axis, which would make them sitting ducks to develop an Addisonian crisis in a stress situation or a febrile illness. And we found out that 1 in 15 people by mathematical modeling may have a risk of dying when they have an acute illness. And we realize it's not enough to publish it and leave it in our medical journals, but it's important to write in the lay press. This is a publication in the national paper called Telegraph in Eastern India, how docs are looking carefully at unregulated steroid use. And then in the electronic media as well, we published this work about steroid overuse behind chronic disease in Bihar town. And this was probably many of our youngsters don't read the newspapers now, so we needed to get it onto the electronic media as well. In 2017, we were quite happy. We had been to the UK, had some higher training, and come back. And we never imagined we'd ever come to Kerala. But what happened was that the Lord we had a situation where our young older son was in boarding school in South India. He was finding it difficult to cope, and so we had to pack our bags and come back to Kerala in a month. And this led to a lot of us. We were a little bit sad this happened, but we realized that God had a different plan. We had a student from the US called Rachel who had came and worked with us, and she was willing to do a study on this problem in a well-educated society in Kerala. And she went to one of our rural communities and did this study. Sorry, just 1 minute. And what we found in this rural study is that there were many patients who were abusing steroids without their knowledge, and many of them were given by pharmacists without a proper prescription. And in 2016, we collated all our research experience in North India, and we published an article in the National Medical Journal of India, which is the top journal with the highest impact factor, where we talked about how we can build research capacity in resource poor settings, our triumphs and challenges. And this is an Australian missionary lady nurse who worked with me, and we put our work together, and this is available online. But along with our research work, what gave me the greatest joy was I had a passion for teaching and training. And along with my colleagues at Roxol, we were able to train many young doctors. One on the left is Dr. Nali, who's currently the director of a mission hospital in Assam. And the one on the right is actually Tony's cousin. Actually, is Dr. Novin, who's married to Dr. Tony's cousin. He's a critical care physician today working in Believers, but he worked for 5 years at the Duncan Hospital with us. And today he has become such a wonderful doctor who's being a blessing to many, many people. And so we were happy to see our junior doctors rise up the ranks and becoming huge influence for kingdom purposes. This is a training program for government doctors, which we did a few years ago. And I was teaching them about how do you interpret an ECG. And many of them were very touched that they had not used an ECG because they were not confident to interpret ECGs. They were all very key influential people in the government sector in Bihar, but they came to Roxol for training. And one of them told me, I don't know why you people are so free and sharing your knowledge. And I was telling him that we have received freely and we freely give. That's what Christ teaches us. And many of them have been deeply touched, and many of them have asked for copies of scripture to see what is the reason behind why we are serving the Lord in those areas. This is visits. We used to often visit students in various parts of Bihar, in Muzaffarpur and Darbhanga, which were big cities in Bihar. And many of these students used to visit us during their holidays, and some of them later on joined and worked as medical students. We used to have blended retreats. In the mornings, they would accompany us on rounds. In the afternoons, after our work is done, we would have teachings on prayer, Bible study, and various other things. And many in that process, they had both spiritual and professional growth in their lives. And when God's love fills our heart, invariably it is splash over, isn't it? These are our chaplains who had counseled many of our patients who had attempted suicides, and they were a key part of our care team. This is my children about 15 years ago when they were small and when we were in Roxall along with Lois, my Australian colleague who worked with us for 10 years and helped to crunch all these numbers and statistics into meaningful papers. Dr. Prabhu on the other side, his family are a pediatrician and orthopedic surgeon who currently serve there at Roxall as the leaders. And we have a wonderful bunch of nurses there who are trained in the nursing college. But we also partnered with evangelical mission organizations which are involved in Bible translation. This is a group of 3 couples who come from different parts of India who were involved in translating the Bible into Bhojpuri who partnered with us. As well as this is one of their home churches where we used to have small worship groups happening quietly. I want to close the last 5 minutes to say that we were very disappointed when God brought us back from Bihar in 2017 to believers in Kerala. We never expected that will happen. But I was encouraged by this a life experience I had when I was in Bihar. When we joined Roxall in 2008, there was a huge bank loan taken and the hospital is being gradually rebuilt. But as many of you know, in 2007, there was a huge economic meltdown which froze further disbursements. And we still had a huge deficit of money to come in, so we couldn't complete the work. For 1 year, we kept praying, Lord, would you not answer our prayer? Give us the money somehow. And we didn't get any answer to prayer. And we were really sad. We used to have all night prayers, fasting prayers, but it seemed to be an agonizing wait for God to answer our prayers. In 2008, at the end of that year, we had a visit from one of our former missionaries, Dr. Peacock. You may remember was one of the persons who published that paper on tetanus way back in 1977. After a gap of 30 years, they came back and visited us. They were in their late 70s. And they heard about how the construction, the rebuilding work of the hospital was halted. And they said they will go back to Scotland, talk to their friends who may perhaps be able to help us. And you won't believe Dr. Joanna Peacock said that one of her patients she had cared for in Scotland when they went back to Scotland in 1975 was a young man called Gordon Mackay. His mother had passed away and she was like his godmother. And he heard about the need and he had originally planned to buy a football club in Scotland. May not be as big as Man U or Liverpool, but he would wanted to buy the Stirling Football Club. And he had set apart money from his savings. And when he heard about this need, he directed it to rebuild our hospital. And we got exactly the money which was needed. 550,000 pounds sterling is roughly the same as 3.3 crores, which we needed. And this is Professor Mackay. He's a world renowned sports medicine arthroscopic surgeon. He operates on rugby players. And he was cared as a young boy by Dr. Joanna Peacock, a erstwhile missionary from the Duncan Hospital in Scotland. And he became a big donor to rebuild. If you go to his Google page, you can Google it out, the Mackay Clinic. He works in the private sector in Scotland and he handles very high profile patients. And he recently discovered the internal brace, which enables people who have sports knee injuries to quickly get back onto their feet and recover faster. And when he came to the Duncan Hospital and inaugurated this new hospital, the next year, this particular brace got a patent. And thereafter, every year, the Duncan Hospital gets close to 1 crore of rupees from the royalties of this brace, which has helped to rebuild the hospital. And he's so magnanimous to continue to keep giving and rebuilding the entire hospital. So this innovation and the royalties continue to rebuild the campus. When I visited Scotland a few years ago, Dr. Joanna said she had a heartbreak in leaving India after 10 years of mission service. But she said I was bitter that God took me away from Roxall. But she said 30 years later, I now see how God used our return to Scotland to bless Roxall 30 years down the line. Her care for a little boy who lost his mother led to the blessing of the mission hospital. Sometimes delayed answer to prayers, although difficult for many years, his divine purposes are revealed in his time. I had a chance to visit in October last year this mission hospital when the Mackay's came again to inaugurate the new nursing college. So I want to conclude by saying that unless we venture out in faith, we cannot see God at work. Moses refused to be known as a son of Pharaoh's daughter. And that's what led him not to be confined in a pyramid, perhaps if he had chosen to stay on as her son. But he went with the people of God. And today, all over the world, we are inspired by his life. We have seen miracles happening firsthand. This first gentleman, Balkishnu Rao, was a man with cerebral malaria who was unconscious for many days in spite of all the right medications we gave him. But prayer brought him back to life. We could see when we held our hands and prayed. Amina Malik is a young lady with severe bleeding from the endotracheal tube in the ICU whose bleeding stopped. We didn't have bronchoscopic facilities, but God did a miracle. And so many other similar stories are there. And isn't it wonderful when we are catalysts for seeing God's kingdom being planted? We don't have to be, our names needn't be, are not so important because it's God's work being done. And we have a privilege, our narratives, to be part of God's meta narrative, what He is doing in this world. And to see our work transform lives firsthand and lead to public health impact in these areas which I talked about. Are there sacrifices? Yes. But truly speaking, these are sacrifices. We have had to give up many things. But today, when I look back, my heart is filled with joy to see how God has used the work. And the work continues. Even though we have left Roxall, God continues to bless the work there. And when you believe today, even though He brought me to Kerala, all our 100 medical students every year go to work in various mission hospitals across India. And that happens because of the connections God gave us over the years. And God is no one's debtor. Are there conflicts in the mission field? There are. I remember every time I used to go for a mission trip, there would be some problem in the family. I remember once my son fell down from a slide, had a head injury, and had to be taken to for a CT scan when I was away, and my wife had to bear the brunt of it. Satan will attack, there's no doubt about it. But God's overarching protection we will experience. So I want to conclude with this slide, which we all know. Two roads diverged in a wood. I had the privilege to travel one which less traveled by. And today, when I look back, that I think has made a huge difference. So thank you very much for your patient listening. I think I've crossed the time a little bit, but I'm happy to take questions. I have about 10 to 15 minutes to take questions if you are awake and there. Thank you and God bless you.